Hello, it's nice to be with you all today to talk about the important role of health literacy as a social determinant of health that contributes to health disparities across both urban and rural American communities. Although health literacy is foundational to ensuring individuals can achieve the highest possible quality of life, it is a determinant that has been poorly measured and overlooked historically. At least that was the case up until the COVID-19 pandemic, which exposed the role of low health literacy played in the public's decreased trust in the health and public health systems, as well as the rapid spread of mis and disinformation. Health literacy is a social risk. It's associated with worse health outcomes and worse healthcare services, associated with racial and ethnic minority status, urban-rural divide, age, poverty, health insurance coverage, educational attainment, etc. And low health literacy is known to lead to individuals more likely visiting emergency rooms, having longer and more hospital stays, less likely to follow treatment plans, and having higher mortality rates. It is generally associated with a greater burden of disease. And the data back from 2003, which is the last national assessment, showed that 36% of Americans had basic to below basic health literacy. So there are a number of evidence-based strategies for enhancing an individual's health literacy, the majority of which focus on the interpersonal level of communication. It's important to remember not to put the onus for change upon the individuals and community themselves, and understand that health communications is a two-way street where the workforce and our organizations have a responsibility to meet the community's needs. So some of the strategies that we can use to improve health literacy are organizational health literacy, a newer concept, which I can describe further in our small group discussion, workforce training, including around teach back, which is an evidence-based methodology, using plain language materials, trying to get to at least a minimum of 5th grade reading level, and then focusing on peer-to-peer health promotion, ensuring that messages are generated and disseminated by near peers and natural leaders who know and understand the cultural and linguistic needs of our communities. And community health workers are an ideal avenue for addressing health literacy because they are more than patient navigators and chronic disease managers. They are trusted and respected members of the communities at greatest risk for low health literacy and thus higher preventable morbidity and mortality. According to the Department of Labor in May 2022, over 60,000 CHWs were employed across the US, but I'm pretty sure that this number is an underestimate, as many CHWs remain quote unquote uncertified. In Texas, these individuals are known as promotores de salud, or their job titles are not a CHW. Additionally, as of fall 2022, HRSA has funded over 80 community health worker training grants with the goal of increasing the workforce by 13,000 people over 3 years. All this to say that this rapidly growing workforce is ideally suited to help address health literacy challenges in the US, ensuring that marginalized populations have access to vital and understandable health information and services. So if our CHWs are an ideal strategy for promoting and addressing low health literacy, how can they do that? Well, one such approach is an asset-based community development model known as community health clubs. This model is simple. Club is a voluntary peer group dedicated to learning about health issues, building consensus around both the challenges and opportunities for change, and then taking action with their new knowledge. This is a health literacy strategy where trained CHWs aim to unlock and acknowledge existing community knowledge and experiences while helping members layer new information or alternative behaviors on top of existing cultures and norms. The lessons learned in the club are spread far and wide through the members themselves, using language and norms that are internal to the community, and then they leverage their social relationships to ensure everyone has access to the same information and services. Now, clubs were started in Southern Africa in the late 1990s and have since been replicated and adapted around the world, including here in South Texas in 2017. To date, over 3,500 clubs have been formed, benefiting well over 3.5 million people. And if you're interested in learning about the important role in CHW starting, facilitating, and sustaining community health clubs, please reach out to the RTTC and the Health Confianza team for more information.
What is graphic journalism? Graphic journalism is nonfiction comics that use traditional reporting techniques to bring information in an easy to digest form. Some of this is most of what I do, which is nonfiction comics that are big, like the example here. So multiple panels, multiple pages. Some other kinds of graphic journalism would be narrative infographics, as an example, turning a pie chart into an actual pie if I'm reporting about the effects of hunger on elementary school students, or being able to use visual aspects to depict agroforestry in a way that people can see what the story is. So it's combining words and images together to bring journalism to life. Ways that graphic journalism can be used. It can be used in place of traditional reporting, and it gives readers a clear source of information. So being able to say, hey, here's all the story, but also with images, be able to say, here's why it's important. Here's how you can care about it. Here's some emotive qualities through images that will let you understand not just what's being said, but why what's being said is important. One of the ways in which graphic journalism can be used is to help people who have struggles with the written word or have a hard time grasping concepts that are really important, but are, either deeply boring or, traumatic in some way. So I can understand with health-based problems, understanding this is exactly how this works. This is a very complex thing. And here's like these very simple, easily broken down ways in which you can understand it, and combining that with visuals that make the ideas clear for people who might otherwise struggle. So what does graphic journalism do that traditional reporting can't? It shows people what something looks or feels like. This is bringing that emotive quality in. It breaks up dense concepts. So I do a lot of reporting on the Farm Bill and on food policy. As an example, I'm working on something right now for the Daily Yonder about SNAP benefits in West Virginia. And it is a difficult and really important thing to be able to understand what the USDA's role is in food security and what the health risks are by not having food security in rural areas. By being able to break this into easy to understand panels, people will have a much easier time figuring out how it is that big nationwide concepts like SNAP benefits affect them. One of the other things this does is it adds an element of timing to storytelling. So panel size depicts the amount of time that you're going to spend in each different panel. So you end up having much more of a narrative concept. It's more like filmmaking or documentary making than it is like a traditional article. So to create a piece of graphic journalism, I rely on traditional fact-based reporting. So I report just like any other reporter. I edit it down to the very basics, getting rid of all superfluous words, bringing it down to about half of the size, and then breaking that into different panels so that I have a really good sense of what the timing is like. And then after that, I add in the images. I let the people who are speaking speak for themselves, and I add images that kind of enhance the story and move the narrative along with that to be able to create something like this comic that explains the way the USDA has disadvantaged Black farmers. And that is how graphic journalism works.
Hi everyone, my name is Megan Hefernan and I am a senior research scientist at NORC at the University of Chicago. I'm really excited to be here today talking to you about NORC's Rural Health Mapping tool. So just to start, local data are critical for decision makers, particularly in rural communities. With funding from the CDC, NORC and East Tennessee State University, ETSU, developed the Rural Health Mapping tool, which is available at ruralhealthmap.norc.org. You'll see that link on the bottom of your screen. The Rural Health Mapping tool includes county-level data on COVID-19, including COVID-19 cases, hospitalizations, deaths, and vaccination, the Prosperity Index, which I'll describe, leading causes of death, sociodemographic factors, economic factors, physical environment, access to healthcare, food environment, and other health outcomes. Local data can be used to support local planning efforts, advocacy, proposal development, allocation of resources, understanding both assets and deficits in your community, and convening partners. So I'm going to show a few of the features on this main base map of the slide. What you'll see here is the base map that is showing the percent that has completed a primary series of the COVID-19 vaccination. If you go to the left-hand panel, you'll be able to see the other variables that you can place on the base map. So you'll see here causes of death is extended. So all of the top leading causes of death, you can add to the map to see that on the base map. You can also look at these COVID-19 outcomes. So as I mentioned, outcomes, vaccination, hospitalization, and the boosters. And then you also can create overlays, which I'll show on the next slide, but you can add overlays for all of these other causes of death. You can add them for sociodemographic, economic, physical environment factors, and so on. So this is what it looks like when you have an overlay of one of the overlay variables. So what we have here is heart disease mortality is the base map, and then we have median household income as the overlay. And you'll see here on the bottom right, the scatter plot. For any two variables on the map, you can actually show the correlation. So I'll zoom in here a bit. This shows you what the graph looks like. So again, it compares median household income and heart disease, and you can see the trend there. You can also look at any given county. So if you hover over one of the counties, it will show you the data points that you have selected for that given county. We also have a county fact sheet for every county in the United States. This county fact sheet provides data for all of the indicators in the tool, including comparisons to your state and to the United States as a whole. So what we have shown here is the causes of death tab, but you can see that you can also access all of the other data sources. So whether that is the COVID data, the other vaccination data, prosperity index, sociodemographic, economic, physical environment, access to healthcare, food environment, or health. And like I mentioned, you'll always see your data for your county and then your state and the United States as a whole. And lastly, I wanted to touch briefly on the Prosperity Index, which is included in this mapping tool. So the Prosperity Index provides data on the single numerical measure that reflects the prosperity of the county. And this is based on 16 indicators, which are included in this table here. And you can access all of the data for those indicators for your county. So you'll see here the example of Jackson County, Alabama. The Prosperity Index is broken up into 4 different components: economic risk, economic resilience, social risk, and social resilience. And you can see the 1 through 5 score, the 1 being the most prosperous and the 5 being the least prosperous for each of those measures. So this is just another variable that you can add as you're exploring the impacts of all of these health outcomes and indicators, and particularly in rural communities, how this impacts your community as you are planning and working towards achieving better outcomes for your communities. Thanks for the opportunity to present today.
Thank you all for coming today. It's my absolute pleasure to be able to talk to you about AI and the future of rural healthcare. I want to start with a principle called Moore's Law that's really about progress. This is a principle from computer science that basically says computer processing speed is going to double every 2 years. And I want you to think about that principle, but apply it to artificial intelligence instead. My version of that is the rate of AI improvement is faster than we can plan conferences to talk about it. In December of 22 last year, it broke the news that an AI for the first time had passed the USMLE Step 1 medical licensure exam. And that was really important. It passed the exam. Everybody was up in arms about it, but we're really no longer talking about passing the exam. We're talking about acing the exam. Today, Open Evidence AI has already become the first AI in history to score above 90% on the exam. Pretty soon, that's going to be 100%, and it's not even going to be in question. We're going to see this continue to grow. Soon, it'll pass Step 3, and then it'll be a fully licensed physician ready to operate. So the first use that I see for AI is in preparation to be a rural healthcare provider. It can be a study partner for those medical board exams. The second is to use AI as an AI-powered medical scribe. This is a tool that already exists today. You can buy it. You can use it in your clinic, in your hospital. It's called Deep Scribe AI. You click a button and it starts listening to a patient encounter, and it transcribes the entire encounter. It's smart enough to filter out small talk, and then it takes those and it generates complete EHR-ready notes for you. So you don't have to, have a scribe in the room with you, a nurse in the room with you, medical assistant. It's going to do that for you. It's preparing your charts for you. All you have to do is review them at the end of the day for accuracy, or after the encounter for accuracy. A third use is to use AI as a diagnostic co-pilot. This is a tool called Glass AI Health. It's currently in beta, but you can access it now. The way it works is you provide a patient summary, and then you click a little button. It says generate differential diagnosis. It's going to generate a differential diagnosis for you. Then you click a second button, generate clinical plan. It's going to tell you how to treat that patient. You have an option at the end to vote it up or vote it down as being accurate or not. So it's actually learning from your feedback, and is going to get more accurate over time to provide better and better healthcare. And I see this primarily as being used as a second opinion before you call your physician buddy down the street, or you call that specialist that you're thinking about referring to, just to make sure that you're on the right track. Finally, and this is my favorite to share with you because it gets a little bit speculative and it's really talking about the near future rather than today, is the use of AI to serve as a medically trained companion. I think about companionship primarily as a form of care in 2 different settings. I'm sure there are others as well that you could think about as well. I'm thinking about nursing home and hospice care, and I'm thinking about children's hospitals where families can't be available 24/7 to provide that kind of companionship, but it's nonetheless critically important for those patients. What you see on the screen here is Keanu Reeves He's not my friend. He's not my neighbor. He's not my relative. He's not my cousin. He didn't pose for these photos for me. These are AI generated photos. I just asked for images of Keanu Reeves dressed as a hospice nurse, and this is what it gave me. The technology exists today to create live video as well. You combine that with large language models like ChatGPT, and you combine it with voice emulation technology, and you get to something very interesting. The first person to do this is going to make $1 billion by making a business out of it. If Keanu Reeves isn't your favorite, then maybe it's Meryl Streep. You can see here, it looks like Meryl Streep, but something's a little bit off. The technology will get there. Give it time. My personal choice would have been Patrick Stewart, Captain Jean-Luc Picard himself. He's who I wanted to be my hospice provider. So take just a moment and listen.
How are you feeling today, Mr. McKenzie? Is there anything I can help you with?
What you just heard was actually my voice modulated to sound like Patrick Stewart's. That's not even necessary. There's other tools that you can type in text. It'll give you the voice. Other tools like ChatGPT that'll actually generate what it has to say and use that voice. That's where I think we're going in the near future. Thanks for having me today. It's been my pleasure.